afternoon and welcome. My name is Lisa Winstel and I'm the Chief Operating Officer of Caregiver Action Network. And on behalf of the nation's family caregivers and the patients that they care for, welcome. Before we get started with what's promising to be a really fantastic panel, and before I turn it over to Sue Peschin, I'm going to take advantage of this moment to introduce you to someone new. And that would be our new CEO. Yesterday, Caregiver Action Network announced that we have hired Marvell Adams Jr. as the CEO of Caregiver Action Network. So here he is. And he is here.
I'm just going to wait. That's all.
All right, now we're going to do this without an echo. How exciting.
Okay.
Thank you very much. I am here today to introduce you to the new CEO of Caregiver Action Network, Marvell Adams Jr. Thank you.
Hi, everyone, and thank you so much for joining us today. I'm Sue Peschin, and I serve as President and CEO of the Alliance for Aging Research, and we're very much excited to join Caregiver Action Network to co-host this timely event, given last week's news. Today, we're going to dig into the exciting FDA approval of a new Alzheimer's therapy, the questions that remain about Medicare coverage, what CMS's requirements mean for other hard-to-treat diseases in the future, and the equity implications for diagnosis and care. We will also explore voter sentiment regarding Medicare coverage of Alzheimer's therapies and potential political considerations. I'm going to take just a few minutes to set the stage for where we are at this moment. Last week, we celebrated the first ever traditional approval of a disease-modifying therapy for Alzheimer's disease by the Food and Drug Administration, or the FDA. Called leqembi, the FDA traditionally approved monoclonal antibody therapy targets amyloid in people with early Alzheimer's. Published data showed the therapy slowed progression of early Alzheimer's by 27% over an 18-month trial. This delay is accompanied by a meaningfully prolonged ability to perform a range of activities, such as the ability to get dressed, do laundry, make a meal, and be left on their own. We all know that these drugs are not a cure. However, many individuals who live with early Alzheimer's or who care about them as family, friend, or clinician believe that these quality of life outcomes are deeply precious and valuable. So they matter. Unfortunately, 15 months ago, the Centers for Medicare and Medicaid Services, or CMS, announced that there wasn't enough evidence for Medicare to cover and pay for any of the FDA-approved early Alzheimer's medications. That final decision in April of 2022 was the first time CMS had declined to cover an entire class of FDA-approved drugs, except for treatments provided through very narrowly constructed coverage with evidence development, or CED, clinical studies. The CED registries and clinical studies CMS requires are deliberately designed for only a small fraction of Medicare beneficiaries, because CED is, in effect, a form of Medicare utilization management. Medicare beneficiaries with early Alzheimer's who can't get into the CED registry or studies won't get coverage. CMS recently released several draft guidance documents, or draft rules, about how the agency plans to use CED more in the future for other types of breakthrough therapies. There are strong signs CMS plans to apply CED to upcoming FDA-approved gene and immunotherapy drugs for cancer, rare conditions, and other diseases. The public can comment on these draft guidances, and we all need to weigh in. On the same day as the FDA's announcement last week, CMS opened a clinician portal and posted a CED registry and study protocol. They did this in response to a lot of pressure from the Alzheimer's community, members of Congress, providers, and attorneys general around the country. And good job, everybody who participated in that. But these materials have raised more questions than they've answered. We've sent a number of questions to CMS, and we await their answers. What we do know is that CMS has promised broad access, and we intend to hold them to it. And that's why we're here today, to discuss how we can all work together to ensure that all patients who may benefit from new innovative treatments can access them as soon as possible. With that, I want to turn it over to our panelists, and we're excited to have an all-star panel joining us today. Mary Perkins is going to be joining us virtually. She's a caregiver to her husband living with Alzheimer's disease. Candace De Mateus is Policy Director for the Partnership to Fight Chronic Disease. Dina Darlington is founder of Links to Equity. Neil Newhouse is partner and co-founder of Public Opinion Strategies. And Kate Gormley is Vice President of Lake Research Partners. Okay, Mary, we're going to get started with you. Can you hear us?
I can.
All right, we can hear you. Could you please share your family caregiving experience with Alzheimer's and how your husband Wes is doing? And please share what happens for the audience here as Alzheimer's progresses and what you see as the disconnect between the FDA and CMS and what that means to you.
I'm happy to do that. Good afternoon, and thank you for the opportunity to share some of our family's journey with this irreversible degenerative brain disease and the impact of the disconnect between the FDA and CMS. My husband is almost 82 and has been experiencing cognitive and memory issues for about 8 years. He was first diagnosed with mild cognitive impairment in 2019 at the Penn Memory Center. We've continued to use the Penn Memory Center for neurology consults and for their very supportive resources and programs. Wes's neurologist changed his diagnosis to mild dementia in 2021 and defined it as late onset Alzheimer's and vascular dementia in 2022. Over the course of the past 2 years, Wes has had to stop driving, is no longer able to safely stay at home by himself. He has difficulty finding and forming words and has experienced hallucinations, delusions, and paranoia, all of which, as you can imagine, make our lives anything but normal. Previously, he was the main cook for our family. Now he is my sous chef. He was the epitome of an outgoing social person. Everybody knew, sorry about it, everybody knew and recognized Wes Perkins. Now he is quiet, speaks softly, searches for words, and waits for others to speak. What would our lives be at this stage if we had access to a drug that could have slowed the progression? We will never know. Knowing now that such a drug is approved is game-changing, but unfortunately, approval does not equal accessible or available. If we were still in the early stages and realized that CMS was blocking our access to a drug that had been approved and could keep Wes functioning at a higher level with a better quality of life for any period of time, I can only imagine the anger and the frustration that I would be experiencing. After surgery last fall, Wes experienced dementia psychosis, which was probably influenced by the anesthesia he received during surgery. This condition wreaked havoc in our lives. It created tension and increased stress, fear, loss of dignity, calls to 911, multiple trips to the emergency room, the need for psychotropic medication, and a 3-month stay in an inpatient facility. This totally changed our lives, socially and financially. An inpatient assisted living personal care memory care unit costs approximately $10,000 to $12,000 per month. To pay for the inpatient stay, I had to deplete Wes's IRA and annuities. He is now covered by Medicaid and is a member of Pace Your Life at the Milford Wellness Village in Delaware. This program is literally saving our lives. There are a lot of misconceptions about Alzheimer's, such as thinking it's just a normal part of aging, or that it's not life-threatening. But those are not the facts. The truth is, Alzheimer's disease is an irreversible degenerative brain condition that results in death, either directly from the disease itself or from a related infection or other complication. It first destroys memory and thinking skills and progresses to an inability to carry out even the simplest of daily tasks, such as washing oneself or using the bathroom. One of the scariest components are the mood and emotional changes, such as depression, anxiety, agitation, and psychosis. Although these commonly occur in people with Alzheimer's, they are not talked about, and finding answers for how to live with these components is almost impossible. FDA approval of an early intervention that slows disease progression is invaluable to every person and family who is living with this disease. This disease is truly a family disease. It's got ramifications for future generations. Slowing its progression is imperative. Treatments such as these give us hope for a better future, one with less burden on family caregivers, because these treatments will provide a longer period of greater independence and have immeasurable impact on the quality of life for individuals and their families. Time matters, and CMS is wrong to deny or delay for so long. Each day, CMS leaves this misguided policy in place. Nearly 3,200 older adults will advance from mild Alzheimer's, where they could experience benefit from this drug, to a more advanced stage. We must do better. And going forward, CMS must be our partner, not a stumbling block to advancing access to the treatments that will be developed as we struggle to combat this disease. Thank you for listening. Thank you for caring. And thank you for taking action.
Go, Mary. That was awesome. Okay, last Thursday, CMS released more information regarding data reporting for providers and beneficiaries to participate in their registry in order to receive Medicare coverage. Candace, could you help us unpack more about Medicare CED registries?
Sure. Sorry, no worries. Great, thank you so much, Sue. And before I get started, I did want to say it is a time for celebration. To have the first ever treatments, FDA-approved treatments, that are actually altering the course of disease. We haven't had an FDA-approved treatment for 20 years until last year. And so now to have two fully approved, FDA-approved treatments is monumental and really marks a sea change for Alzheimer's disease. But of course, that depends on people having coverage and having access. Sue also alluded to the fact that it's not just about Alzheimer's disease. This is a very dangerous precedent. And you see a lot in the media. The CMS administrator also testified to and misstated that somehow accelerated approval, FDA accelerated approval, is not full FDA approval, and that's incorrect. Accelerated approval is full FDA approval. There's traditional and accelerated, and they both are full FDA approval. And the proof's in the pudding. Just ask the people covered by the VA who've had access to leqembi for months, while people on Medicare have been sitting and waiting. On the registries and this portal that was recently launched, they did launch it on the day that leqembi received FDA traditional approval. It is free, which is a huge help because a lot of times these registries are quite expensive to participate in. But there are still a lot of questions about this portal. And two important ones are, how will this requirement, this data entry, registration, how will that limit access to underserved populations? And that's critically important. We know significant disparities exist, and I know we're going to hear more about that, but how is this again, another hurdle to access going to impact those populations. And how long is CMS going to keep this restriction on coverage in place? The data collection we know from the portal that they're requiring is at least 24 months per patient. So if they were to start today, they'd have to follow them for 24 months and enter that data. Data collection is not a study. So they're accumulating the data, but that's not answering the questions. There still has to be collecting the data for over thousands of patients, and then someone has to request access, design a study, request access, get approval from CMS to have access to the data, do the analysis, publish the results, and then there's a whole reconsideration process to follow that. So at a minimum, we're looking at least 4 years for this to stay in place, and that's optimistic. And that's just for leqembi. We have other drugs in the pipeline, and is that process going to start over for them? According to CMS, unless we keep the pressure on and treat people with Alzheimer's disease the same way we treat everybody else in terms of coverage for FDA-approved therapies under Medicare, unfortunately, that's what we're looking at. CMS's record on registries also is not great in terms of access. The one CMS itself continues to cite is the TAVR registry. That's transaortic valve replacement registry. TAVR is a procedure that helps people with aortic stenosis, which has a 50% fatality rate at 2 years for the serious form of the disease if it is not taken care of. So very serious illness. That registry has been in place for more than 11 years. The registry has data on more than 100,000 patients. It has 30 plus clinical trials and clinical studies published in the literature, and still the coverage is continuing to require evidence development, and access is limited. An analysis done a few years back showed significant disparities with respect to access to TAVR, hitting Black Americans, other communities of color, people living in rural areas, which 1 in 5 older Americans lives in a rural area, and lower income populations the hardest. But during reconsideration of this TAVR registry, which Medicare decided to continue this coverage with evidence development, that did not include an assessment or an acknowledgement of the role of the registry and the coverage with evidence development, how that impacted these disparities or exacerbated the health inequities. Instead, it was used as a reason to keep that limitation in place. Oh, we need more data on these populations who aren't being served, so therefore we need to keep this barrier in place. So oftentimes we're hearing, and candidly hearing feedback from staff, well, isn't more research a good thing? Isn't more data a good thing? Shouldn't we be collecting more data? The answer is, of course, more data, more information is a good thing, but not at the cost of inequity and denying people access and limiting access, particularly to vulnerable and underserved populations. We included some materials in the back that goes through this in much more detail. Happy to answer any questions about that, or if you get back to the office and want to ask questions, please feel free to reach out and talk to us about this, because it is a huge burden. And even if the portal is free and, we're only asking a few questions, that's still a hurdle. And we know that for many people, they're already encountering barriers to access, and putting one more barrier in place will mean that fewer people have access and coverage. These resources demonstrate the challenges ahead. Unfortunately, our work is not done, and until people with Alzheimer's disease, they're not asking for special treatment. They're just asking to be treated the same and have the same access to FDA-approved therapies that everybody else does in Medicare. So I'll pause there. Thanks so much, Sue.
Thanks, Candace. All right. So Candace spoke to this a bit, but Dina is going to share more about it. CMS's decision really is as much, if not more, of an equity issue as it is a disease state issue for people in underserved rural areas and communities of color. So Dina is going to share a bit more about the broader equity implications of CMS's decision. One thing I just want to put a finer point on that Candace did bring up is this idea of post-data collection, post-FDA approval, which all of us are very much supportive of. But the fine point is that it should not be a condition of coverage. That's the point. You shouldn't have to it shouldn't impinge on being able to get a therapy on whether or not you're able to get access to a clinical study. And that's what's happening here. Dina? Sure.
Thank you, Sue, and good afternoon, everyone. I am thrilled to be here to talk about this topic. It's professionally as well as personally very important. My dad was diagnosed with dementia with Lewy bodies, so I totally understand this experience from a caregiver perspective, but also from a family perspective. And I think our patient spoke earlier of how this is really a family issue. So I'd like to talk a little bit, start off my discussion with some of the disparities and how does this impact Black and brown communities, but also more underserved and historically marginalized communities. To provide a bit of level setting, right now there's 6.7 million Americans aged 65 and under diagnosed with Alzheimer's. When you look at subpopulations, let's look at the Black or African American community. They're 2 times more likely to be diagnosed with Alzheimer's. When we look at our Latino community, 1.5 times more likely to be diagnosed with this disease. And then let's look at women as a subpopulation. 2/3 of women are diagnosed with Alzheimer's in this Medicare population. But then to take that intersectionality even further as it pertains to a caregiver, who's caring for our Alzheimer's patients? And they're women. So we have that double intersectionality associated with caregivers and women and Alzheimer's. So that's just to level set us and talk a little bit about what are the disparities. And we can see that our historically marginalized communities, it's real, it's there. So let's talk about the CED and how does that impact these communities. So we know that you have to register for the CED. And when you think about that, I think we have to think about the history of medical research in our country and what the impact of that on marginalized communities. We all know about the Tuskegee research that was conducted in our country, but there's other research that we don't always know very much about. So there's real reason for these people to have a distrust within our medical research system that we have. And that is going to further exacerbate the health disparities in Alzheimer's, because I'm going to give you some quotes from the Alzheimer's Association. They have reported that 62% of Black Americans believe that medical research is biased against people of color. 45% of Asian Americans hold the same belief as well. And then we also have 36% of Hispanic Americans believing in this, and 40% of Native Americans. So those folks are going to be very hesitant to enroll in this registry, just based upon their beliefs on how this information will be used for them or against them based upon their history. And I'm not saying that is the case at all, but we can't erase that mistrust that exists. And when we have that type of distrust, we're going to have a lower number of underserved populations actually wanting to enroll in this registry. So we're going to have a great decline of more diverse populations engaging in this. So this is yet another barrier that, I'm sure that this was not intentional from a CMS standpoint, but I do think that we needed to think a little bit more about the impact, considering the stats that we have on underserved populations and their experience with the Alzheimer's disease. In addition to this from a racial and ethnic standpoint, I think we also have to think about it at a geographic standpoint. We know that providers in rural communities, they don't have the staff, they don't have the resources to really participate in this type of research. So we have to think about that, and also the intersectionality of lower income folks in those regions, in rural regions. So again, we see that these populations will have a very disparate outcome as it pertains to accessing this medicine. And I think that there's been a lot of research that since this was implemented, there has been a lot of research based upon some of the new drug approvals and submissions to the FDA for CMS to look at this information, also based upon the CEDs that they've had in place for a year. So they have the research that I frankly believe needs to be reconsidered and evaluated prior to furthering this type of policy and restricting even more greater access to vulnerable populations. And I'll just finalize my comments by saying that this is very unfortunate and very dangerous and a slippery slope to go down this path with Alzheimer's, and using Alzheimer's as the example. There's other diseases that are fully FDA approved. There is no CED in effect for them. So why are we beginning to use one of the most critical diseases out there impacting Americans across the country with this horrific disease and using them as the poster child to start this process or to actually execute on this registry concept? So I'll pause there. I'm happy to answer questions at the end, but thank you so much for your time and your attention today.
Thanks, Dina, and we will have time for questions at the end. So Kate and Neil, in May, Lake Research Partners and Public Opinion Strategies fielded a survey of 1,000 likely voters that was commissioned by Us Against Alzheimer's, the LEAD Coalition, the Global Alzheimer's Platform Foundation, and the Alliance. So what do likely voters think of all of this? And I know we have some slides for you all.
Thank you, Sue. I get to present the poll findings, and Neil is here to provide the color commentary. So as Sue outlined, we were in the field in May 1st through 7th this year. This was a phone survey. It was nationwide. We partnered with Neil and his team. It was a great partnership. We talked to our base sample of 1,000 likely 2024 voters, and we also talked to additional samples of 100 Black likely 2024 voters, 100 likely Latino and Latina likely 2024 voters, and then we also talked to an additional sample of 75 likely 2024 voters who are in some key states: Arizona, Montana, Nevada, Ohio, Pennsylvania, Wisconsin, and West Virginia. What we did with those extra interviews was we weighted them back down into the thousands so that they are represented in the universe as they should be. And we have those extra interviews so that we have large enough groups to look at among these three cohorts of voters. The overall margin of error is plus or minus 2.7, and Neil, jump in, please.
Just one thing. If you don't know our background in our firms, Lake Research is a dominant Democratic polling firm in the country, one of the most respected, and our firm is a Republican firm. So we have bipartisan across the board to kind of provide us a check on each other on this, but it's a bipartisan survey that we work together on this thing. That's why I think this has more weight than a normal survey would have.
That's right, thank you. Okay, so before I show you some of the findings and some beautiful graphs and tables, I want to just give you an overview of the big picture findings from this survey. The findings are remarkably consistent, and there's a lot of intensity to all of the questions that we asked. So the first really key thing that stood out to Neil's team and to our team is that voters are eager to see action on this issue. They overwhelmingly favor requiring Medicare to cover the costs of FDA-approved drugs and therapies that can slow the progression of Alzheimer's disease. And when I show you that graph, you will see what I mean when I say there is overwhelming favorability for this. Like you have heard the other panelists discuss, when we surveyed our voters, they said, if Medicare beneficiaries are getting access to other FDA-approved medications. They should also get access to these, just like they do everything else. They agreed with that. This is a personal issue to many voters. We had just over half who say they have a personal connection to the disease, whether it's themselves, a family member, or a friend. And that's true across gender lines, across age cohorts, across racial subgroups, and across partisan lines as well. So this is really an issue that is impacting many different cohorts of the electorate. Not only is this something that people are dealing with and experiencing, they're looking ahead to the future and they're worried about what could happen. So a majority of folks told us that they are concerned that themselves, a friend or family member could develop Alzheimer's disease in the future. If Medicare does not step in and cover these FDA-approved drugs and therapies for Alzheimer's disease, then voters want to see Congress and the president step in and take action. Again, there is widespread agreement with this desire to see both Congress and the president step in that crosses all kinds of different demographic subgroups that we looked at. They think it's important that patients have access to these FDA-approved drugs, and that it's important that they're covered by Medicare. We tested a range of statements about Medicare covering these medications for Alzheimer's disease, and those resonated very strongly as well. And again, it's, if other medications are being covered that are FDA approved, why not this one? If the folks who get their insurance through the Veterans Administration are getting this covered, why not Medicare beneficiaries? And the final big picture finding here is that if there was a candidate who said that they agree and that Medicare should cover the cost of FDA-approved drugs, that actually makes voters more likely to support that candidate. All right,
Okay.
Neil?
Yeah, let me just, one point here. Kate and I, and our firms do a ton of research, and I'm sure you all follow the news, et cetera. We live in an extraordinarily polarized political environment. Republicans hate Democrats, Democrats hate Republicans. They don't see the same issues the same way. This issue is an anomaly. There is almost universality of support for this issue. It comes as close to unanimity as any issue we have recently tested. And I think that's really important. And so when you see Kate going through this data, and you look at this data, and she's going to be focusing on the strong support. Strong support is in the 80s. Overall support is in the 90s. In addition to that, there is very little opposition. Nobody's against this thing. The opposition is 6 to 10%. So this is one of these remarkable issues that cuts across party lines, cuts across age, generation, ethnicity, and it's one of the few issues that Kate and I have an opportunity on where we both absolutely agree on the findings.
Yeah, just remarkable intensity across the board for really all of these questions. And like Neil said, this is not typical to have the agreement across the board and to also have the real intense reactions to the various ways we pose these questions. Okay, so here's our first example of this in action. You can see nearly 9 in 10 voters, when asked, do you favor or oppose requiring Medicare to cover the cost of FDA-approved drugs and therapies that can slow the progression of Alzheimer's disease? 87% say I favor that. 77% strongly favor it. We cannot get 77% of Americans to agree on almost anything. So this is just incredible overall favorability and then intense favorability as well. Just to underscore how rare this is. And
so Republicans are at 83 to 6, Democrats at 93 to 2. Less than 10% of Republicans disagree with this.
As I mentioned in the introduction to our findings, we asked people, okay, so let's just imagine that Medicare does not cover FDA-approved drugs and therapies. Then do you think Congress should step in? What about the president? And you can see here we have on the left side reactions to Congress stepping in and requiring Medicare to cover these drugs and therapies. And on the right, we have the president. And again, just remarkable agreement here. We have about 3/4 who strongly agree with Congress stepping in, and nearly 2/3 who strongly agree with the president stepping in. I know this is a wall of numbers here, but we wanted to illustrate for you how intense and consistent the support is across subgroups. So again, we have Congress on the left, the president on the right. We are showing you these findings across gender, age cohorts, party identification, race, if people have a personal connection to the disease or not, region, and who they voted for in 2020. And you can see here, like Neil has alluded to, just remarkable agreement across the board for both Congress stepping in and requiring Medicare to cover these drugs and therapies, as well as the president.
So one thing to note here, I'm going to stand up to point this one. Republicans, 7% of Republicans approve of the job President Biden's doing. Get back to the slide. And yet, 63% agree the president should step in to cover this. This goes against every fiber of their being. But they believe the president should still step in and do it, which gives you an idea of the intensity of this issue and the support across party lines.
As I mentioned in my intro, we tested a variety of statements here and asked voters, do you agree or disagree with them? And you can see here we have at least 80% who strongly agree with all of these statements, over 90% who agree with them overall. When we take the people who agree minus the people who disagree, the margins are in the 80s. I mean, just overwhelming agreement here. And the things that they're agreeing to are, like I've said, this should be covered the same way Medicare covers all other FDA-approved medications for all other diseases. They have covered every drug approved by the FDA, and it shouldn't be different for drugs to treat Alzheimer's. They should allow the patients and the doctors to make decisions based on risks, benefits, and individual health needs. The VA has made the decision to cover these new drugs and has been covering these new drugs, and so Medicare should cover them as well. And then lastly, that really plain and simple here, Medicare should be required to cover drugs that are FDA approved. No?
Yeah, the only thing here is, it's not just the approval and strong approval. Nobody disagrees. We tested 9 of these statements. On not a single one did opposition hit above 10%.
And again, this is something that folks are agreeing with regardless of their race, their age, their gender, the part of the country that they're living in. They are strongly agreeing with these statements. We have a significant percentage of the country who has a personal connection to Alzheimer's disease. We heard from Mary earlier. So we have 40% who say, yes, my family member has had Alzheimer's disease, 16% who say, yes, it's a friend, and then 1% say, it is me. 45% said, this is not something that personally impacts me. So this is a personal issue for so many voters in America, but also the other side of that is it doesn't have to be a personal issue for people to care about this and to want to see action. We also looked at caregivers. So who is out there currently providing or in the past providing regular care or assistance to someone with Alzheimer's disease, and it's about 1/4 who are either doing it currently or in the past, or currently and in the past. So there's a significant portion of the country out there as well who are caregivers for people with Alzheimer's disease.
Yeah, I just thought these are stunning numbers. The number of Americans who have personal experience with Alzheimer's is incredible. And Kate's going to show you the next chart. It cuts across the board again. Young, old, men, women, and bipartisanship. It's not just people who are, who are older who are dealing with their, their spouses, their partners.
That's right. And you can see those numbers right here. It cuts across men and women, different age cohorts. It cuts across party, and it cuts across race as well. We see that, women, older voters, and Republicans and Hispanic voters are a little bit more likely than other cohorts to be current caregivers or have ever provided care or assistance to someone in the past who has had Alzheimer's disease. The last thing that we want to go over, I'm sorry, Neil, did you have anything?
No.
Okay, great. Okay, the last thing to go over is, so what happens if a candidate for elected office comes out and says, I support this stance. I want to require Medicare to cover these FDA-approved drugs and therapies that can slow the progression of Alzheimer's disease. And over half of voters say that that makes me more likely to vote for that candidate. We have a third who say, you know what, great, that doesn't make a difference to me either way. Only 3% say that that makes them less likely. So there's no opposition for somebody taking this position. Just overwhelming, again, support, and they like the idea of somebody who's running for elected office supporting this as well.
Yeah, on this one, we do see partisan differences. And it's interesting and it's important, especially for those of you who may be advising your boss or advising a member of Congress in re-election stuff. But Republicans say they're more likely to vote for a candidate who supports this by 37-3, Democrats by 68-2. So I take that from that two things. Number one, this is not going to hurt a Republican candidate who takes this position in a Republican primary. You're not going to get penalized for this in a Republican primary. And secondly, it could help Republicans. I'm a Republican pollster. It can help Republicans sway independent and Democratic voters to their position. So that's the key criteria. It doesn't hurt you in a primary, helps you in a general election. And that the key number on this slide is not the 52%, but as Kate pointed out, it's that 3% less likely. There's no opposition. There's nobody who's less likely to vote for this thing. It's a safe position for legislators.
And that is what we have to share. We're also happy to answer any questions that you may have. Thank you for having us.
That's perfect. Thank you both. That was terrific. So I have one last question for everybody on the panel, and then we're going to open it up. And it's not required, but it is open to everybody if you guys would like to answer. And my last question, it's your chance here. What message do you have for policymakers and staff that are here today? Go ahead, Candace.
I'll start. First of all, thank you. Thank you for being here. Thank you for caring about this issue. For those who've been championing this, thank you, thank you, thank you. Our work isn't done. We still need your help. And I hope that we've given you information today, but if we haven't, if you need more information, please reach out, because we need to get this across the finish line so people have access, so they have this option and have the coverage that they need.
I'll just say thank you as well for being here and caring about this topic. And also, I think it's important that we consider the disparities that I mentioned earlier, the vulnerable populations that are diagnosed with this. You know, part of my remarks, I did not even speak to a delay in diagnosis that these patients often experience living in, whether it's in a rural environment or whether just not having access to treatment. So I think it would be super helpful if Congress could urge CMS to reconsider their thinking, to relook at the data that is now available, but also to educate, for CMS to really go back and look at how am I impacting disparities? Am I further exacerbating this issue? And then go back to the drawing board and think of a better way to provide access to Alzheimer's patients.
Briefly, I'd tell you that, tell your bosses this issue impacts a hell of a lot more people than you think it does. I mean, the 52% who know someone, the 27% who have taken care of someone, that, and there is near unanimity of support for these proposals.
And to build on that, I would add that, like I said, you don't have to be directly impacted. There are a lot of people that are directly impacted by this, a lot of caregivers out there. There are a lot of people who are worried about what is going to happen to themselves and their families in the future. And we don't get the high levels of agreement and high levels of favorability if we don't also bring along the people who are not personally impacted. So it's rare to see a poll with these kinds of numbers and this kind of broad agreement. Just to underscore that one more time.
Okay, thanks to all of you. The only thing I would add is just that we
May I
need...
also add something?
Oh, I'm sorry, Mary. Yes, please.
I want to reiterate what others have said about thank you. Thank you for being here today, and thank you for listening and for caring. And I also want you to take a moment and look at your own family. Look at your friends look at your colleagues, look around your local community, and really see who the people are who may be dealing with this disease. Please keep them and the struggling and grieving families who support them in your mind as you make decisions and you put forth policy. Take action. You really can make a difference in this. Thank you.
Thank you, Mary. Awesome. Yes, I have nothing more to add on that. I do want to open it up for any questions in the audience. We also still have Mary on the line, so please include her if you have questions. And please just state your name and where you're from prior to your question.
Hi, I'm Mark Gibbons with Retire Safe. So more of an observation about the survey and then a question for Deanna. So I'm pleased about the survey. I see that normally Republicans will always ask what's the dollar amount associated with this, and that was not the case here. Everyone was in favor of, the president giving forth the authority or Congress or whoever, so I'm glad to see that. So that was hopeful for me. In regards to the people of color, brown and black, disparities, whether it's in Southeast DC, Baltimore, or McAllen, Texas, or Lyford, Texas, I think the problem that we're finding, and I think hopefully the staffers will take this back, is that there are a lot of trust issues that we still need to break down, and it's educating. And the trust issues go back, it's more about stories being passed down from generation to generation. And so we have to figure out some way to go into those communities and talk to those people and assure them that this is for the good for them. So I know that you're looking into that, but is there some other way that you can think of that we can maybe ask the staffers to go back to their bosses and help push this issue?
Thanks, Mark. Yeah, you're absolutely correct. The way to address this is to really go in at a community level and educate about some of the atrocities that may have occurred historically from a clinical trial standpoint or from a medical research. So that's my response, is to go directly to the community and educate. But also CMS needs to also take on that opportunity as well to engage at a community level on this topic. And I will say that, when we look at the black and brown communities on this topic, there's a major caregiving issue as well that needs to be addressed, because there's a different concept with black and brown families as it pertains to caregivers. We think about families providing care for their loved ones with Alzheimer's, but there's also this external caregiver help or paid caregiver help that can support our Alzheimer's patients. Oftentimes, black and brown communities, when they say caregiver, they think of themselves or their family member. So there's this whole gap around caregiving as well that exists and further perpetuate this. And finally, I'll say the biggest struggle here, Mark, is yes, community needs to be engaged, but moreover, this policy needs to be reconsidered, because that's the impetus to why the community has to be engaged. So we really have to go backwards and address this policy, because it's just restricting access to people that need this innovation.
Can I have one thing just for a minute? You mentioned cost, because I know that there's some statistics, and I would say, again, very misleading statistics about this leqembi and the cost to Medicare. You heard Mary talk about, and I had a similar experience with my mother-in-law, the cost of long-term care in a memory facility is $9,000 to $12,000 to $13,000 a year, and a month. And that doesn't alleviate all your caregiving responsibilities either. It certainly helps, but there's still a lot of burden on the family that you have to take care of, and you want to. And I hate to even use the word burden, but it's true. So when you look at a medicine that's going to cost $26,500 a year, I think is what it is, a year, and you can delay someone perhaps needing to enter a facility by months, you've covered the cost in 2 months of delay. So please just keep that in mind. There are also a number of statistics, like they're way overestimating the population that would have access, that qualifies, that meets the criteria for this medicine, to kind of inflate and cause alarm. But I just draw your attention back to It's the first time we've ever had something that changes the course of illness, and it's a very expensive and devastating illness, and we need to look at that whole picture when we talk about cost.
Absolutely. Great answer, Candace. I would also add, I mean, when you say it's the first disease-modifying therapy, to think about, you know, cancer, there are a lot of different types of cancer, conditions like MS, where there are second, third, fourth line therapies that we are currently paying for in these programs. And to say, okay, now you have your first one, you may have a large population, or, you know, we just can't afford it all of a sudden, it really does sort of bring up a question of discrimination. Why Alzheimer's? And it is opening up this door. So CMS had never done this before for any other drug successfully. They've done it here, so now they will be able to do it. So even though you may say not it for your particular area that you might be concerned about, it's something they're doing a lot more work on to shore up. And the one last thing I would add to Mark's question, I do think it's important to take a look in your districts, in your states, how many neurologists you have. You know, it's not really clear that we have enough folks in terms of what's required under these strict coverage guidelines to actually distribute this therapy. And CMS, you know, we know a lot of very good-hearted people there. But in terms of some of the messaging on this, not entirely clear with the public about who is a qualified physician, where are qualified facilities, and a bunch of the other requirements that are part of the coverage criteria. So those are kind of these open questions that we need to ask, and just really want to encourage your bosses, especially as you go into summer break periods, to talk about these issues with constituents, to ask these questions, to ask things at the local level, and to keep pressing on the agency, because claims really can't be put into CMS until the end of July. Well, that's kind of convenient. That's when things go quiet in Washington. Don't let this go quiet. Other questions?
Thank you. I'm Anna. I'm with Congressman Nadler's office. This is a little bit, I guess, tangential, but related to, you know, Medicare coverage. So how will the disparity of the effect of leqembi between like men and women separately, how did that play a part in like FDA approval, and like will like the effectiveness of the drug on men versus women play a part in like Medicare coverage and the approval of that in the future?
The impact of, that's so interesting that you, where did you hear there was a difference in terms of effectiveness on men versus women?
I think there was an article that popped up somewhere that said that, you know, it was like men found that the drug was more effective than women did. I'm not sure if that's true or not. It might not be.
I don't believe so. I am, having followed the, you know, and I am not a physician, not a reviewer at the FDA, all of that, but having followed this issue pretty closely, that really has not come up as an issue. It's, there have been more kind of characteristics related to genetics, for example, but not related to male versus female.
Okay, great. Just wanted to fact check myself.
Absolutely.
My name is Cassie White, and I'm here on behalf of the Men's Health Network. I'm just curious as to what are some ways that we can promote and encourage people to get screened earlier so that they can catch their Alzheimer's at its earlier stage.
Go ahead.
If you want to make a question. Sure. I'll start it off, and I'll just say from an education standpoint and a stigma standpoint. So I think that it's important that we educate so that we can remove some of the stigma and fear associated with this diagnosis. And oftentimes it's not just the patient that may have that fear and stigma, it's their children and the family. So I think the more we can erase stigma through education, that will help us get this earlier diagnosis.
And I agree, the stigma is a really tough one. And I think, candidly, we have to be honest with ourselves. I mean, we're all forgetful, but I think a lot of times people downplay dementia, like, oh, it's just forgetful, and it's not a normal part of aging. You know, I forget where my cell phone is. You know, when somebody forgets the conversation they had with you, 5 hours earlier, that's a different scenario. There's some great screening tools that are available, but I think, we need to be candid and seek that out and understand the stigma too, and be able to address that. Absolutely. But you're right. Early diagnosis and screening is so important. And I know there are screening events. Alzheimer's Association has many of those, and those are really important to tap into.
I also believe that once the public hears more about the availability of a medication that can help to slow the progression, that is going to encourage people to want to go and get screened who are very hesitant to do it, because there'll be a reason to do it. Right now, too many people feel, so what if I get the diagnosis? There's nothing I can do about it. And that's where this drug and other future drugs will make a big impact.
Absolutely. That is a great answer, Mary. I definitely think that having, therapies also not just for individuals, but for clinicians too, because when they feel helpless, like there's not much they can offer their patients, there may be less of an incentive to want to kind of see whether or not somebody might have problems with their cognition or potentially are at risk of Alzheimer's disease. Because if you don't have much to offer as a doctor, you feel kind of helpless yourself. So this adds hope in that regard. And the Alzheimer's Association has pointed this out, that this approval will really mean a lot in terms of improving screening and detection of the illness. So it's important to point it out. I did just want to say that
Cassie, one other thing. If you've watched TV lately, Kareem Abdul-Jabbar's got an ad on TV that talks about his diagnosis as AFib.
Yes.
And he talks about how he noticed it and how he wrote it off, but then he finally went to the doctor. It's that kind of warning signs that I think we need to be talking about in our community. But I thought that was a really interesting ad. It then encouraged people to go get tested early and just don't write it off as something that happens.
Sue, one other thing I was going to say, screening is important. There's also diagnosis. There is another NCD with CED in place that's limiting access to PET scans, which is, how you can scan the brain to see where the amyloid plaques are, and the degree to which plaques are in the brain. So a really important diagnostic tool that helps physicians diagnose Alzheimer's and tell whether amyloid plaques, qualify people for treatment. That you are only allowed one per lifetime currently within Medicare, and that's a major problem. They have said they are going to reconsider it. We expected a decision, I think it was December. They said March. We're still waiting. And at least as of 6 a.m. this morning when I last checked the news, they still had not issued that. So that's another huge hurdle. The other option is a lumbar puncture, which sounds as awful as, is probably as awful as it sounds. But that also doesn't tell you where in the brain the plaques are. It also doesn't, if you are under treatment, how well is the therapy working, where are the plaques clearing and the like. So really important as well.
And Sue, I'll just also say that when you look at the health inequities associated with that, there's already a great delay in diagnosis in vulnerable populations. So just another roadblock for them trying to get a diagnosis so that they can reach treatment under the policy that was just referenced. So it's just a domino effect, and that vulnerable population, they're going to be, really impacted more so than the broader.
Yeah, I just wanted to thank Katrin Werner on my team for actually finding the study that was asked about men versus women, and just came out. So good, I see that you saw it in the news. They actually said that the results were found to not be statistically significant. It said, quote, the gender disparities were not found to be statistically significant, which essentially means the observed difference happened by chance. So, all right. Well, thank you all so much for coming. We have
a couple more questions.
Oh.
Just one more, I'll be really quick.
Okay.
Because I know we all got stuff to do. Is this on? All right, sorry. My name is Sean. I'm with Congresswoman Salazar's office. First, thank you all for coming by and enlightening us all on this very, very important topic. I think one quick comment, the conversation around detection and diagnosis is great in this room because it's so critical to so many things, not only our understanding of the disease, but in allowing people to access these treatments, particularly leqembi, because it's only available to people with early stage dementia or early onset Alzheimer's. My question is for Mary. Mary, real quick, if you wouldn't mind, with particular regard to leqembi, the slowing of the progression of the disease, I believe, across 18 months was in 6 months on average. Can you speak to the importance of those extra 6 months to either people who don't think that is significant enough, either for Medicare to cover it or for families to go out and seek that potential treatment?
In all honesty, 1 day, 1 week, 1 month extra would be a plus. 6 months right now actually sounds like a luxury. When you've been living with it and you see the devastation and you see how quickly things can change and how they can progress and go downhill so quickly, 6 months of extra time of being able to plan, being able to enjoy, being able to live a semi-normal life, it's huge, absolutely huge. If you could take the last 6 months out of my life and go 6 months back, I would probably pay $1 million for that.
Oh, wow.
Thank you, Mary, and thank you for all you do.
Thank you for the question. That was a great way to wrap up. We have materials for folks to take who are here in the room. We're going to be, amplifying the recording of this, so please help us do that. And we look forward to working with all of you. Please join me in thanking our panelists today. And Mary, too. Thank you so much, Mary.
You're very welcome. It was my pleasure.
Thanks, everybody, for joining us. Have a great day.